So let's now look at vitamin K. Vitamin K's primary purpose in life, besides causing us to have questions on the exam, is to introduce calcium binding sites on any calcium binding proteins. You know, the modification that allows the calcium binding site is direct out of biochemistry. It is the gamma carboxylation of glutamate in these proteins, what we call gamma carboxylation of glutamic acid, that will allow that calcium binding. The famous proteins that require gamma carboxylation and for which some physiopath depends on are the clotting factors 2, prothrombin, 7 from the extrinsic pathway, 9 from the intrinsic pathway, 10 from the common coagulation pathway, but also the anticoagulant proteins C and S. How can I understand that famous gamma carboxylation? I need a diagram, and here's a fantastic diagram to understand the process. Look, what you're seeing here is the site where gamma carboxylation will occur. And make sure you understand that the site where this happens is the liver, not in the blood. So this is not a process that occurs inside your bloodstream, it's a process that occurs inside the hepatocyte. And it occurs, as you can see very well, as the ribosome is translating the messenger RNA for these clotting factors. Like for instance, imagine that it is in the process of translating prothrombin, which is factor 2. When it's making prothrombin, imagine further that the little black dot is a glutamic acid. That glutamic acid already has one carboxyl, CO-. What vitamin K will allow is the gamma carboxylation by the enzyme gamma-glutamyl carboxylase of that glutamate. What gamma carboxylation does is put a second carboxyl on that side chain. That second carboxyl now allows prothrombin to have 2 negative charges. You see those 2 negative charges? Well, guess who's going to be happy to bind the 2 negative charges? The 2 positive charges of calcium. Therefore, calcium binding only occurs if you have adequate gamma carboxylation of the protein. Here the clotting factors while they're being made in your liver, not in your blood, and certainly then you're going to have the action of making an active prothrombin once in the blood, which will be factor 2 becomes factor 2A, and then as you know, you'll be able to turn on fibrinogen into fibrin and make a thrombus. With this in mind then, vitamin K deficiency is bound to be associated with significant bleeding, and if we want anticoagulant effect in pharmacology, one big group of drugs will be the one that look like vitamin K and can block the gamma carboxylation of glutamate in factors 2, 7, 9, 10, but also protein C and protein S. Well, then it means if I have vitamin K deficiency, just like vitamin C deficiency, I should see easy bruising and potential bleeding. Easy bruising and bleeding. That means this is it. I'm lost. They look identical. I'll never know which one is which. Are you kidding me? That's the only thing that is similar between the 2 vitamin deficiencies. Everything else is different. So play with that table and you can answer any question of K or C deficiencies. Look, if we start with a vitamin K deficiency, what do we see? First, in the laboratory, I see an absolutely normal bleeding time. Bleeding time is going to measure whether yes or no you have an appropriate platelet function. You know, the idea is to make a small injury to a vessel and literally take a timer and see how long will it take for the bleeding to stop. It shouldn't take more than 2 to 9 minutes. That is because platelets, if all goes fine, will be able to stick to the damaged endothelium with VWF, get activated, and then aggregate to form a temporary platelet thrombus. Bleeding time will only be affected, therefore, in vitamin C deficiency because there is defective collagen, and a defect in collagen will interfere with the first step of the platelet pathway, which is adhesion. There's no platelet problems whatsoever in vitamin K deficiency. Conversely, in the laboratory, vitamin K deficiency will increase prothrombin time, whereas vitamin C deficiency will have a normal prothrombin time. Let's see this one. You'll review in your pathology that a prothrombin time is basically testing the following question. does calcium trigger coagulation in vitro? Basically, we're adding tons of calcium to a blood sample, and then we're measuring how quickly can it become a clot in the test tube. Well, you can add lots of calcium. If you don't have gamma carboxylation, it will not trigger coagulation. So PT is longer in vitamin K deficiency. Vitamin C deficiency does not affect clotting factors. Therefore, there's an absolutely normal PT. So lab-wise, you can confuse. How about symptoms-wise? Surely they both have easy bruising and bleeding. But in vitamin K, you have no connective tissue problem. In vitamin C deficiency, you have a defect in collagen, therefore you have tons of connective tissue problem. Anything from loose teeth that fall off, you sneeze and a couple teeth blows off, skeletal deformities, poor wound healing, anemia, none of this you see with vitamin K deficiency. And if that wasn't enough, now you also add to this the history of the patient. We know vitamin C is dietary. Deficiency in citrus or green vegetable. Vitamin K is not a dietary deficiency, it's fat malabsorption. Fat malabsorption, it could occur because of drugs, particularly drugs that cause fat malabsorption, maybe drugs to lower lipids, such as cholestyramine, such as cholesterol. You remember the bile sequestering resins. It could, of course, be pancreatic type of injuries, the pancreas being responsible for producing lipase. Pancreatitis could be an issue. You know who has pancreatic insufficiency? Cystic fibrosis patients. I'm going to put CF, and the board has loved in pathology to put cystic fibrosis and test you on vitamin K deficiency. Pretty neat, huh? Besides pancreatic diseases, fat malabsorption may also happen simply because of diet and you don't eat enough fat. It could happen because you don't have the right lipoproteins being made. You know, imagine you don't have B48 to carry the actual dietary lipid into your blood. More to come on this in the lipid metabolism section of your biochem book. If it's not fat malabsorption, it's long-term antibiotic therapy. Drugs again. Antibiotics, they kill gut bacteria. Remember that a big chunk of our vitamin K comes from gut bacteria. So no doubt, that could be a reason for vitamin K deficiency. You just have to take it for 10 days or so, and it needs to be a broad-spectrum antibiotic, maybe a cephalosporin, for instance. Then for another potential, breastfed newborn. First, the newborn doesn't have a gut flora. With no gut flora, they cannot produce endogenous vitamin K. And number two, breast milk is very poor in vitamin K. Now, normally you'll see in the perinatal period, we're going to inject several vitamins in that baby to make sure there's no deficiency, one of which is going to be vitamin K, so it should be very unlikely. The one that is most unlikely but still potentially tested would be the infant whose mom is taking anticonvulsant therapy during pregnancy. It's unlikely because if you remember well your farm, taking drugs like phenytoin, carbamazepine is teratogenic. So more often than not, people on anticonvulsants do not become pregnant. But phenytoin, carbamazepine, and even barbiturate, even the phenobarb that is actually used in pregnancy when we have a patient with epilepsy. Well, all three cause problems with vitamin K, and as such, will further magnify the risk of developing deficiency in the newborn. So really everything is different between vitamin K and vitamin C deficiency. You should not be confusing them just based on easy bruising and bleeding. Look at the rest of the story, you should be able to come up with which one is which. Finally, as an important integration, anticoagulant therapy may involve the drug warfarin, or really what we call coumarins, dicumarol being another one of those. Warfarin, coumarins are vitamin K analogs. It means they look like vitamin K. They're used orally because they're lipid soluble, and what they do is prevent the gamma carboxylation of the clotting factors. So what they will block is the co-translational modification during the synthesis of the actual factors in the liver. It is working in the liver, but not in the blood. So one very important point is that warfarin and dicumarol, they can only prevent coagulation in vivo. You cannot put warfarin in a test tube and imagine you'll prevent coagulation of blood in vitro. Obviously, you're not in the process of making clotting factors in the blood. They've already been made. So only when you get in the liver. And then number 2, you're going to see that warfarin and dicumarol then, they're going to take a couple to 3 days before they work. Because when you initiate the treatment, the active gamma carboxylated factors are already in the blood of the patient, and you're going to need to wait until they run out of these factors before you see the full effect of warfarin. That's because warfarin is working on the liver on the next generation of clotting factors. During these 2-3 days, a big worry would be that you would have thrombosis. Well, you're going to give heparin at the same time when you initiate the treatment. As a matter of fact, thrombosis is even more likely, as you'll see in your pharmacology, from the standpoint that warfarin can cause a transient protein C deficiency. And that transient protein C deficiency comes from the fact that protein C also required gamma carboxylation, and it has a much shorter half-life than most of the clotting factors in the blood. So we're going to run out of the anticoagulant protein C before we run out of the actual clotting factors. You must heparinize a patient when you put them on warfarin.